The following video describes an endoscopic double pulley technique which provides medial row tendon compression while avoiding the need for antegrade or retrograde suture passage. We present the case of a 52-year-old female with a 2-year history of right anterolateral hip, buttock, and back pain with no inciting event. She describes a progressive hip discomfort with prolonged walking in addition to a noticeable limp. She also reports the inability to lay directly on her right side. Of note, she has had previous trochanteric bursal injection, which offered her temporary relief, in addition to an ultrasound-guided intra-articular hip injection, which did not improve her symptoms. On physical exam, the patient demonstrated Trendelenburg gait and positive Trendelenburg sign. Other features of note included reduced abductor strength, pain to palpation over the greater trochanter, in addition to pain to palpation of the abductor musculature. These are two pertinent images from the MRI in the sagittal and coronal plane, demonstrating full thickness tear at the medius and minimus footprint, in addition to fluid signal overlying the greater trochanter. Under fluoroscopic guidance, an 18-gauge spinal needle is used to target the vastus ridge to establish a proximal anterolateral viewing portal. A distal anterolateral working portal with cannula is then established for later suture management. Utilizing a 70-degree scope, the borders of the tear are identified. Radiofrequency ablator or shaver can be used as a probe to enter the greater trochanteric bursa and palpate the greater trochanter. The greater trochanter footprint is then debrided. The decision is made for the number of medial row anchors to be used. Here we are using 2 self-tapping double-loaded Stryker Iconic Speed anchors. The anchors are spaced 1 to 2 centimeters apart depending on tear dimensions and advance through the glute medius and minimus tendon at the level of the myotendinous junction. These anchors are advanced under fluoroscopic guidance to confirm position in the trochanter. After placing the double-loaded suture anchors, 1 limb from each anchor is mated to a single limb of the same color from the other anchor and pulled out through the cannula. This is repeated with a single limb of the second color from both anchors. Once outside the cannula, the same colored limbs are tied together over a finger or a switching stick using a square knot, and the tails are cut short. The previously untouched purple limbs are then pulled to draw the tied ends through the cannula and down onto the tendon, creating a bridge between the 2 anchors and compressing the tendon. This is then repeated for the white sutures. This creates the medial row. The remaining untied limbs are then retrieved through the cannula and placed into a 4.75 millimeter self-tapping anchor. The anchor is appropriately tensioned and advanced distal to the bridging row, establishing the lateral row anchor in an inverted triangle configuration. The repair is then gently tested with internal and external rotation of the hip. At 3 months postoperatively, the patient demonstrated drastically improved lateral hip pain, normalized gait without limp, and a negative Trendelenburg sign, in addition to significantly improved resisted abduction strength. Thank you.